Hey everyone on Facebook and on YouTube. I'm your program coordinator for the Missouri Science and Technology Policy Initiative Local Science Engagement Network, Dan English, and we are live on this long weekend, Friday afternoon. Thank you for staying late and joining us. I really appreciate it. Today we've got an important topic to talk about: mental health in Missouri and all the challenges that people face acquiring mental health care and all the barriers that may be in place for people who want to get mental health care. But before we get to that, and maybe Dr. Bickle will join me in promoting this, next Friday, we've got biogas in Missouri. Dr. Bickle, I'm gonna put you on air. Do you want to give us a quick update about what our biogas discussion is going to be about?
Yeah, absolutely. I don't know if you can see me. I can't see me, but yeah, we're gonna be hosting next month, June, at the end of June. We're gonna have experts on biogas. We're gonna have some researchers here from the University of Missouri, but also stakeholders who work in the biogas industry. We may also have somebody from the utility side of the conversation, but biogas is a really neat part of the renewable energy sources of energy. And it's definitely something that our state has a lot going on. So we're really excited to show you some from the very best experts on our state.
Yeah, that's going to be coming up at the end of June. And if you want to register for that, go to MissouriLSEN.quorum.us and scroll all the way down to the bottom of the page on your bottom right-hand side, and that's where you can click to register to be a part of that. Like I said, I'm Dan English. That's most fellow Dr. Eleni Bickel, PhD from the University of Missouri. I also want to bring on Rosie Dutt. Rosie, how are you doing today? Rosie is a dual master's degree recipient in engineering and research, I think. I can't remember. But more importantly, Rosie is also a PhD candidate at Washington University in St. Louis. Rosie, how are you today?
I'm good, thank you. It's very hot. I'm currently in Atlanta. So.
Okay. And since these two are, they're over there, these two are our mental health experts, I'm going to let them take over the discussion, and I'm going to pop in whenever anybody has a question. If you're watching at home or on your computer at school, click on the comment section below and type your questions in there, and we'll get our questions in front of our panel. And without further ado, here I go. I'll let Rosie and Dr. Bickle take it over. Thanks.
Great. So I guess I'll begin providing a little bit of a background into mental health in Missouri. But more broadly, I wanted to start off with the definition of mental health, and that usually includes emotional, psychological, and social well-being. It affects how we think, how we feel, how we act, and it can also help determine how we handle stress, relate to others, and make choices. Each year, about 51 million adults in the US experience mental illnesses. When you consider a 2-year average, in 2020, the Department of Health and Human Services actually reported over 300,000 Missourians had a serious mental illness in the past year. For example, reports of an individual suffering from one major depressive disorder in the state of Missouri is much higher. It's at about 18.6%. compared to the national average of about 14.5%. Furthermore, the state of Missouri actually ranks 38th for having a higher prevalence of mental health and lower access to care. And these lack of resources actually result in health disparities, especially for rural Missourians and specifically Missouri minorities who have been shown to have a lower socioeconomic status than their urban non-minority counterparts. Counties in the boot heel of Missouri, such as Mississippi, New Madrid, Scott, Penobscot, and Dunkling, have shown some of the highest percentage of minorities, specifically including African American and Hispanic residents. Both Mississippi and New Madrid do not have a hospital, and they only have one rural health center each, and one federally qualified health center actually exists in New Madrid County. So research has actually indicated that a combination of determinants of of minority health alongside limited access and care in rural areas proves to be detrimental for minorities living in rural Missouri. And additional studies have also indicated that rural patients actually face greater transportation barriers to healthcare access than their urban counterparts. And since 1 in 3 Missourians actually reside and are rural citizens, it is important that methods are identified for healthcare accessibility. So with that, I'll hand it over to Eleni, who will provide some details on how farm stress has an issue in terms of Missouri.
Yeah, thanks, Rosie. Hello, everybody, again, and thank you so much for joining us today on this virtual roundtable discussion on mental health in Missouri. As all of you may know, this is the month that we celebrate and we raise awareness on mental health. So as an organization, we're very proud to be holding a lot of these roundtables, and I'm glad to finish this month off with this important topic. My name is Dr. Elaine Bickel, and I'll be your co-host together with Rose today. I have a PhD in agricultural and applied economics from the University of Missouri, and I serve as the Agricultural Science Policy Fellow at the Missouri Science Technology Policy Initiative, or as we call it, MOST Policy Initiative. MOST Policy Initiative is a nonprofit organization based in Jefferson City, and we aim to bring scientific resources to Missouri policymakers. We work with lawmakers side by side to advise them on scientific topics related to the bills that they work on. And then we also have events like this where we try to bring together researchers and policymakers on important scientific and policy topics such as mental health. I come from a farming town, and I have been working with farmers and agricultural professionals from all walks of life for my entire adult life. And one thing that has come up time and time again is farm stress. Stress can be, in general, a very powerful tool for growth, as it can help us promote like that type of initiative to get things done. But whenever stress becomes acute or chronic, it can really interfere with our daily activities. And especially so if you're a farmer, because farming is dangerous and stressful, and farmers, for that reason, can have varying degrees of resiliency to how they deal with physical and mental challenges on farming. And also we see different levels of stresses in different farmers. There are two main reasons that make stress to be more present in farm settings than we see it in other settings. The first one is the unpredictable aspect of farming. This is related to the financial markets. For example, how much do you have to plant, how much you want to store, how much you want to save, how much you want to sell, and when to sell, and all those kind of attributes. The second reason why stress is more prevalent in farm settings is because of the unpredictability of the weather. It is, we have a lot of material, a lot of resources in our hands to be able to predict how the weather is going to look like, but we have very little control over what we do when we have extended periods of droughts or floods. So these two can really cause unique situation of stress on farmers, but also farm families. And then now that we know what farm stress is, why do we have to care about it? Well, the reason why we have to care is because the most important asset in the food chain, from the producer all the way to the consumer, is the farmer. And farmers and ranchers' mental health is positively correlated with both how well their livestock health is doing, but also their crop production is doing if they're farmers. And then for that reason, now that we know that what farm stress is and how it can impact more farmers, we should probably all agree that that farmers should be able to find treatment and help for their stress, right? However, what we see based on practice and research and various reports from our state is that there is a shortage, and as Rosie also mentioned, there is a shortage of psychologists and psychiatrists in rural Missouri. There are actually half as many as in metropolitan areas. In 2021, all but one Missouri counties were designated as mental health desert areas, and 57 rural counties of those had 0 mental health professionals. To talk about farm stress today, mental health, and also how healthcare access depends on where you're located and more, we have experts from both academia and policymaking. Then we have our speakers on the line.
Yeah, we have our speakers on the line. Let's introduce Senator Greg Razor from Kansas City. Senator Razor, how are you doing today?
I'm good. How are you all?
Doing great. We have Dr. Patricia Alifari from University of Missouri.
Hello.
Dr. Alifari, how are you today?
Just fine.
Just fine. Okay, Elizabeth Condon is a legislative assistant. Elizabeth, how are you doing today? Thank you for joining us.
I'm good,
And
thanks.
last but not least is Xavier Ransom, a newly minted dual master's degree recipient from, was it Washington University or St. Louis University?
University of Missouri, Columbia.
That's right. I got it wrong. Sorry. I'll go away. See, I'll let you guys have your discussion. Thank you very much. I'll be out.
Great. Thank you.
Okay, so I'm going to go ahead and introduce the policy makers, speakers that we have here with us today. Senator Razor, thank you so much for being with us today. Senator Razor is a Democrat. He's the state senator for the 7th senatorial district, and he's serving a portion of the Jackson County. He was first elected to serve in the Senate in 2020, and he previously served for 2 terms in the Missouri House of Representatives. Prior to his legislative duties, Senator Razor was Deputy Regional Director for the U.S. Senate Schools from 2008 up to 2016. Senator Razor holds a bachelor's degree in history from the University of Columbia. 5 years. Yeah. Our second speaker from the policymakers side is Ms. Elizabeth Condon. Elizabeth. She's a legislative assistant to Representative Wabona Applebaum, who serves as the ranking minority member of the House Health and Mental Health Policy Committee at the Missouri House of Representatives. Elizabeth has served in the state legislature since 2017, first as an intern with Senator Jill Shue, and then as a legislative assistant. She graduated from Truman State University with a bachelor's degree in political science and is now in the process of applying to graduate schools to pursue a master's degree in public health. Rosie.
Great. Can everyone hear me okay? Just making sure the signal's clear. Okay, cool. Great. So I'll be introducing Dr. Patricia Alifari, who finds solutions that enable physicians and health providers to work more effectively. Dr. Alifari investigates how clinicians can most effectively use information technology to enhance their practices. Among other topics, she studies the factors that lead to mental health inpatient recidivism, so return to care, because 1 in 4 persons needing mental health services do not receive care. A better understanding of set circumstances leading to recidivism could contribute to clinicians' abilities to serve more individuals. So Dr. Alifari has written numerous scholarly articles. Recent publications center on developing tools and processes to increase treatment adherence. She regularly presents at industry conferences and has contributed significantly to developments of standards around physician-supplied data and usability. Additionally, Dr. Alifari is involved in the formulation of national policy, serving as the chair of the Rural Health Community of Practice, a national group that examines solutions to rural health issues. She also directs the Missouri Health Technology Assistance Center and maintains an active consulting practice. So Dr. Alifari does a lot. Now we're going to move on to our final guest, Mr. Ransom, who just graduated with a dual master's and is actually under the mentorship of Dr. Alifari. So I'm sure you guys can say hello. But yeah, so Xavier is an avid proponent of battling healthcare inequalities through using data science to inform policy initiatives. During his master's thesis, Xavier used an open source platform to geospatially map healthcare inequities within the state of Missouri, which highlighted how different socioeconomic factors increased readmission rates of psychiatric patients within 30 days, as referred to as psychiatric recidivism. Additionally, Xavier completed an administrative internship at Mount Sinai Health Systems in New York City, where his work focused on maternal mortality to highlight inequities in healthcare. He was also selected as a scholar for the American Healthcare Association for his contributions to promote health equity and diversity within healthcare. At present, Xavier works as a data analyst for the Government Employee Health Association, where he works at the intersection of data science and population health analytics for health insurance. So that's a bit of a review of all our speakers here today. Seen that Dr. Bickle has dropped off, but I'm sure she'll be back on shortly. But without further ado, I'm sure everyone is very busy on this very special weekend for Americans. So without further ado, I'll take it away with question one, which is in relation to the first topic, which is healthcare and rural communities. So the first question is to Mr. Ransom and Dr. Alifari. Mr. Ransom, you can go first. And the question is, what tools exist to help address healthcare disparity?
Okay, thank you, Rosie. So given that many Americans live in disadvantaged neighborhoods, which have been linked to several healthcare outcomes, including higher rates of mental illness, hospital readmissions, increased utilization of health services, and earlier deaths, health interventions and policies that do not account for neighborhood disadvantages have been reported to be ineffective, and more needs to be done in this regard. So the Health Resources and Services Administration developed the Area Deprivation Index, or ADI, which allows for the ranking of neighborhoods by socioeconomic status disadvantage in the regions of interest. So thank you for sharing my first figure. This is a map that I developed for my thesis, which indicates the ADI geospatially mapped for the state of Missouri. A higher ADI range between 7 and 10 out of a 10-point scale is seen in more rural areas when compared to cities, which have a significantly lower ADI, which is a range between 0 and 2 out of a 10-point scale. So when you take a look at the map, the classic Boot Hill area in the bottom right of the screen has long been considered a very rural and more socially disadvantaged area. However, in the east and west portions of Missouri, you see the cities of Kansas City and St. Louis, which have a lower ADI and thus are very light in the color gradient.
Great, thank you for that, Xavier. So I wanted to ask Dr. Alifari if you know of any tools that currently exist to address healthcare disparities in addition to the ADI.
Quite a lot of data. The problem is, how do you move from data to some sort of community-based solution? So, we see counties in Missouri. I think the last time I looked, there was 60 counties that didn't have a psychiatrist. And as already been pointed out, 57 counties out of the 114 that have no mental health services at all. So this creates access issues, particularly since those areas oftentimes don't have anything that looks like public transportation. So we may have very long travel distances. One of the data sets I look at fairly regularly has to do with patients who are referred to the Missouri Psychiatric Center, which is associated with the university here in Columbia, and what the travel distance looks like. And it seems to me like it's a sad situation when we have not just one or two people, but a whole bunch of folks who are traveling in excess of 4 hours to get here to receive care. And when you think about even outpatient psychiatric care as being at best a monthly visit, typically psychiatric medications, for example, are not prescribed for longer than 30 days. It's a real burden on individuals, and it's pretty easy to understand how those disparities begin to happen because we have long distances, we have other kinds of access issues. So we could talk about the way the roads go in Missouri and how that leads to the disparities in care and so on. But the whole situation is we don't have folks in communities who can provide the services, and transport distances can really get long.
Since Eleanie's internet connection dropped out, I will take over her question. This question is directed at Senator Razor and Dr. Alifari. You know, you both come from rural communities, but and Senator Razor, you represent an urban district. How have the different experiences you've had in the two different communities impacted your approach to implementing policy on mental health parity?
Well, so I grew up, it was interesting hearing Xavier talk and talk about the Boot Hill being historically a socially disadvantaged area. I grew up in Pemiscot County, which is probably the poorest of the counties in the Boot Hill. I now represent downtown Kansas City. And if you know Kansas City, the Midtown Plaza, Brookside, Waldo, some of the most affluent parts of our state. But one of the things that I think I'm able to do is to talk to each side in a way that they will understand. I think it's important to talk about farm stress. I know a family farmer in Pemiscot County who committed suicide. It's years of financial stress, it's years of physical work. It's years of worry about chemicals that they are around and medical conditions that causes. You can then turn that around, and I can talk to folks back at home in Kansas City about it who are facing business stress and more of a white collar job environment. I can go to my rural colleagues and talk about the stress of what it must be like to live in a 25-year-old trailer home with, random access to unreliable vehicles. Get them to understand that I appreciate that about their community, and then introduce them to what it must be like to live in a disadvantaged neighborhood in the inner city. Transportation problems that we have, whether you're in St. Louis or Kansas City. The difficulty it is, whether you're in Pemiscot County or Jackson County, to get to the grocery store, to buy those groceries, to get those groceries home, all the things that add up to mental health problems. And so what I see from Pemiscot County to Jackson County is the issues look very different, but when you boil it down, they're the exact same issues. And it's just getting across that line of, on a policy standpoint, of getting people to understand that fact, that we're all dealing with the same issues, they just look different. That is something. One thing I did want to point out when we were talking about farm stress and lack of access to mental health providers in rural areas in particular, is we have to have demand for that. And I think part of that demand issue that we see in rural Missouri is a byproduct of toxic masculinity. I know I was brought up to not ask for help. Men aren't supposed to ask for help. And I think that extends to women in rural Missouri quite a bit as well. In farming communities, you got to just get out there and get it done. You don't have time for self-care, as they might put it. And I think that's something that we need to overcome, is getting people to understand that mental health is simply health.
Very interesting. Rosie, you have an interesting question coming up about stigma, and I think Senator Razor talked a little bit about that. You take it away.
Mm-hmm. Sure. So this is pointed at Dr. Alifari in addition to the previous question. We wanted to know a little bit about what's the stigma associated with mental health and getting mental health care in rural communities.
I think Mr. Razor correctly identified a culture, if you will, of being self-sufficient as maybe one of the drivers. But there are other issues, I think, also in the more rural areas. One of those is oftentimes that the population that is at least more inclined towards suicide and those kinds of things in rural populations does tend to be older than we see in an urban environment. And probably the other big issue around stigma is not so much the stigma itself, but the anxiety about being stigmatized. And when we look at rural environments, anonymity is really hard in those environments. Population's not very dense. Everybody knows everybody. You're probably related to half the people in the county. I know in my case, I can go up here to Pettis County and drive through a whole section of it and tell you who lives in each one of those houses and how they're related to me. Yeah, it's that kind of a situation. And then we have, difficulties if you're already feeling like you're having trouble reaching out for mental health care. Then you have that added burden of not being probably able to do so without having some incursion into your privacy. So that adds to that layer of stigma. And I think in rural population, that's a very realistic scenario. I also think that we see situations where particularly suicide is underreported. Maybe all mental health issues are underreported, but certainly the suicide rates although they look higher than the national average, they're probably significantly underreported. I've worked with some public health departments in some of those counties, and it's pretty much an acknowledged fact that some individuals had a hunting accident, had a motor vehicle accident, and so on, but that it actually probably was suicide. So I think we've got several issues laying on top that creates this, at least anxiety about the stigma.
Sandra Razor, I think I'm back. Sandra Razor, I had another question when you brought up the stigma, which is something that is very important in this conversation that we have, especially when we talk about Missourians or rural Missourians. How do you think that the mental health parity, which is something that you have worked really hard on as a piece of legislation, is going to help us destigmatize mental health needs and getting help for people who need mental health? Can you talk a little bit about what that means?
Sure. I don't know if the legislation of the mental health parity bill will help with the stigmatizing of it. It will certainly help in accessing either mental health care or the medication that might be needed. I think as we have this conversation, and I see lots of head nodding when we talk about stigma, and we all understand that. And I'm thinking as a 17-year-old closeted gay kid growing up in Pemiscot County, I needed to talk to a professional. And I remember the anxiety of my car being seen parked in front of that office. I think one of the things that is happening as we're all sitting here in this conversation, sounds more and more dire, is to step back and look at a 50,000-foot view for just a moment and think that this year in the state of Missouri, in our legislature, we had real, honest, frank conversations about mental health issues and how to access the treatment. And at least on a policy level, that conversation happened and legislation was passed, which I'm not sure that could have happened 10 years ago. I'm not sure elected officials would have been that open and frank about it. We did that on a number of topics that just even 10 years ago were taboo: mental health, HIV, needle drug use. These are issues that, while to us that are working on it on a day-to-day basis, it seems like we're moving at a snail's pace, we're actually making progress. And unfortunately, underserved communities, whether they be in rural Missouri or in our urban communities, wherever there's underserved communities, they historically are going to kind of trail where we would like to see them. But that means it's up to us to keep having the conversation, to keep breaking down those stigmas, to make sure that people all across the state know that there is no shame in needing mental health treatment, that it's something that happens to everyone, that it's a health condition like any other, and treatment needs to be made available. So hopefully this legislation will make that treatment more readily available, at least more affordable when it is available. And then we have to continue to break down the stigma. Dan, I think you're muted.
Every single time. Thank you. Thank you, Senator Azar, for getting my back on that. I just wanted to pop in here and turn the conversation towards a Facebook question that we got. Jody Jackson Jr. says, the conversation has focused so far on access to psychiatric and psychological services. Most mental health care, such as therapy and related mental health counseling, is provided by professional counselors and licensed clinical social workers. I'm guessing those professionals are in short supply in rural areas. Is that accurate? Anybody who wants to chime in can take this one.
The distribution of counselors, behavioral health counselors, clinical social workers, and so on might be a little better than a psychiatrist, but it's still not good. And there are many communities that do not have direct access to that either, to those kinds of services. And when we do see behavioral health services available, counseling, substance abuse to a certain degree, and so on, they may exist in isolation from what we would call psychiatric or even a general physician. We have to understand that in rural communities, even general practitioners are in short supply. There are counties in Missouri that do not have one, let alone enough to handle the burden. Marion County, sometimes it's a little iffy as to whether they actually have a single provider or they don't, depending on which side of the line that individual falls on. So you don't have the backup support infrastructure in place if you're a counselor or a clinical social worker or someone. You may not have a direct conduit to a physician that can help you, or you may not have a conduit to a lab that can do the kinds of testing you need, those sorts of things. So it's the whole infrastructure that's missing.
Yeah, and just to piggyback off of Dr. Alifari, an interesting stat that I found during my thesis was that more than 80% of all counties in the United States, or more than 60% of all counties in the United States, including 80% of all rural counties, do not have a single psychiatrist within them. So this is not just a regional or a state issue. This is more of a national issue as far as having the resources and mental health support and services.
Great. Well, that concludes the first topic that we were going to talk about in terms of healthcare and rural communities. The next topic we'll be focusing on is mental health access, needs, challenges, and resources. And I know, Elizabeth, you've been very patient as there has been so much conversation going on. So my question is directed to you for this second topic. And the question is regarding sort of what challenges do you sort of see in low income communities and individuals with substance use disorders?
Sure. So to preface this, so Representative Applebaum's district is relatively middle or upper income. We don't have a whole lot of lower income folks in the district. We have a handful, but it's not very large. So for this question, I reached out to Representative Kimberly Ann Collins, who represents the 77th district in the city of St. Louis, which, if it's not the poorest district in the state, it's close to it. And she mentioned that low-income communities are often characterized by poor housing, limited resources, and inadequate schools with low funding that comes from the state. High crime and violence, all of those things are associated with poor mental health outcomes. She mentioned that in North St.
Not sure if we've just lost Elizabeth there. Is that true? Yeah, okay. Okay, well,
Well, if that's the case, we do have some technology issues today. I apologize for that. We can jump on the next question that we have here until Elizabeth gets back with us. Telemedicine and services offered through technology were brought up frequently this year at the General Assembly. My question is again addressed to Senator Razor, but feel free to jump in and provide your personal view on this. How do you think technology affects both the patient but also the health practitioner? And what steps have you seen that have been made that help us access mental health care? And what other steps you think that we still need to undertake? Senator Razor, if you can answer that, and then anybody can complete. Thank you.
You know, to be honest, I would like to hear from you all about how using technology affects, you know, especially in a therapeutic type situation. I would think when I'm thinking back to, you know, Pemiscot County, where there is a lack of access, any access is going to be great. Of course, you're going to have access to broadband in order to get that, which is still a problem in rural Missouri, one that I hope that we can address, one that I know that is talked about a lot. It's time that we finally do something about it. But if that access to broadband is there, then I would think using technology as a conduit is better than nothing. However, there is also something about, and maybe somebody else can put this into better words. I'm frankly going from my own personal experience here. There is something about being in a room with someone else. There's something about that physical human interaction, especially during very difficult moments in a person's life, that you just can't get from a screen. Having said that, if talking to someone via Zoom is the best that we can do, then I would think by all means we need to be accessing that.
Yeah. Thank you, Senator Razor. I would like to share my thoughts on the matter. So within telemedicine and I guess services offered through technology, you see this shift to machine learning and using machine learning and artificial intelligence to provide that kind of link to mental health and to provide patients a link to health service providers. As a part of a think tank innovation competition I was a part of held by Siemens, we ended up creating a chatbot which can aid in mental health of patients. So we ended up winning the competition on this idea that patients can speak to the chatbot, and the chatbot using machine learning and different AI techniques can relay the information it receives from the patient in form of text or emojis or certain characters that the patient uses, and kind of predict and send that information and predict what patients are more critically in need of mental health services, as in suicide prevention. And so this type of technology really is first being developed right now, as currently we speak, and it allows for patients to, or actually practitioners are experiencing a new phenomenon called digital trust, where patients are more likely to share more deeper information about themselves and their mental stability to a machine or an AI learning or a chatbot, rather than to a clinician who's maybe there face to face. So I think that's just one of the things. If I refer to Dr. Alifari to gain even more further insight on this topic.
I've heard the digital trust a couple of times. It's kind of a two-edged sword in some ways, I think. Some patients really do better with a digital kind of access. We've been using telemedicine, of course, for psychiatry for 20, 25 years now. but that tends to be the clinical psychiatrists that use telemedicine. And some patients do much better with it. And it allows us to extend the services to places that are not otherwise easy to extend. If you look at the overlap between mental health concerns and the population of folks we have in our criminal justice system, there's a really big overlap. And I've seen some statistics that suggest that, 20-25% or so, with the raw data that I have from several places around here, it's closer to 80%. 80% of folks who are currently in the criminal justice system someplace have a mental health condition that really ought to be treated. And telemedicine can help us extend into that population as well. So there's lots of ways to use it. But it goes back to that same issue. We can use the tools, the telemedicine, the digital access, the electronic medical records, and so on. But if the infrastructure is not there in the community to support that use, it doesn't happen. And the example I point out, and I won't tell you which county hospital it was I was in because I don't want to embarrass them, but I made a 2.5-hour drive, which will give you an idea of where it is, to a hospital to work on some stuff up there with their information systems to find a $40,000 telemedicine equipment in their conference room. And I said, why did I make this drive? Because I could have spent a lot more time helping you if I wasn't making a 5-hour round trip, to find out that no one knew how to turn it on. So, and there was no one in the community that could help them with this. And their tech resources in that hospital was 1/2 of 1 FTE that they shared with the local bank. That's the kind of things that we're missing. We don't have that infrastructure in place. So it makes it really hard to use what might be some really cost-effective technology. So broadband's a big issue, but there's a lot of other parts, I think, to it as well. That's my thought.
Great. Thank you very much.
Could I ask a quick question? This is maybe to Xavier. When we look at, I believe you said that there are just some people that do better, chatting with kind of AI, and I don't know if you would use the word triage, but I heard kind of triage the most urgent cases to someone else. But is there a demographic that we see with people who do better with AI than with an actual person? And I'm wondering if that might be a way around some of, masculinity issues, when we see farm stress of just societal that you shouldn't ask for help. Well, if I'm talking to a computer, I'm not asking a person for help. Are we seeing that sort of thing? Is it random? I'm just curious. Or did my question make sense?
Yeah, definitely. So the milder the mental health conditions, the better it does well, but not for schizophrenic patients, not for things like more serious like depressive disorder or schizophrenic, as they have an issue with trust. And so when it's more is along a gradient in terms of severity of the psychiatric condition, rather than a specific demographic, as in more male or female, or based on race or socioeconomic status. So this is currently all in development right now. So there really isn't much detail. For example, the use of virtual assistants, as I was speaking on earlier, which goes on to the chatbot. The Amazon Alexa just was able to receive clearance for HIPAA, clearance as far as HIPAA and access to information or health information. So this is all just very, very new.
I was just going to say that from a personal experience and talking with a lot of farmers, young farmers primarily, because most of them are free to speak about these topics and feel comfortable. I think a combination of both, something that is affordable, is pretty much the best way to go, especially with young people like myself and my family. Like something that we used over the pandemic was a combination of both, like a hybrid, where you would sign up and you would have a psychiatrist from Kansas City, and they would like talk with you once a week, and then you would have unlimited text messages, which I thought was really neat because I would not be able to afford that when I was a graduate student, and I definitely needed some help, but that was not an option for so many people and so many of my friends. But now it is an option with like less than what you pay for a gym. You can have now an expert, a professional who can give you so unique advice that is really like targeted through your needs. And I think farmers, like coming back to the stigma, farmers might be also a group of people who might be willing to do it more through text because they don't want to be like, they're like, you know, the whole stigma and everything. They're just raised in a different culture where you have to just man up and go and do it, and that mental health is not actually a health problem and it's just in your mind. So yeah, just to give like a personal perspective, I think it's great. And I think, Javier, on your like point, I think we're going to have a lot of amazing data in the coming years, which we're going to be like comparing demographics and what is working better with different age groups.
Great. So I'll circle back to Elizabeth shortly, but sort of following on from the current question, line of questioning, I guess one of the questions that I have is, how does data science have the ability to inform policy in the field of mental health? So I guess I'll first ask Xavier, and then I'm sure Dr. Alifari has some stuff to say, and then anyone else can sort of chip in there.
Sure. Thank you, Rosie. So as an individual who works at the intersection of data science and health informatics, I believe data science has several ways to inform policy. So during my thesis, I looked at socioeconomic factors which impacted the psychiatric recidivism in the state of Missouri. So if you don't know, psychiatric recidivism refers to an individual being readmitted to a hospital or psychiatric center within 30 days. Here I use data science specifically to an open access computer language known as Python to geospatially map the location of recidivists, depicted as the black cross on the screen now, and compared these to non-recidivists, or depicted as a green circle. So this was on the state of Missouri within the block groups of the area deprivation index, depicted as a diverging color bar seen to the left of the figure. So there are 5 quintiles ranging from quintile 1, least disadvantaged, to quintile 5, which is most disadvantaged. So this figure shows the location of recidivists and non-recidivists geospatially mapped on the ADI map of Missouri for patients who were documented with the use of restraints. So from the figure, both non-recidivists and recidivists are located within the same area. However, a pattern of recidivists is seen in the mid and southeastern areas of Missouri, aka the Boot Hill area, which corresponds with the higher ADI quintiles. Interestingly, there is an absence of patient recidivists with documented use of restraints in both the St. Louis and Kansas City areas, as seen in the east and western portion of the map. So, however, there's a pattern of recidivists seen in the mid and southeastern portion of Missouri. And so this could be attributed to the fact that both St. Louis and Kansas City have counties with jails available in comparison to mid and southeastern counties, which do not have jails available. So this is further compounded by the fact that 17% of all admissions to Missouri's prisons were considered mentally ill, and compared to 9% admitted in 2000. And as the stat I stated earlier, 60% of U.S. counties do not have a single practicing psychiatrist available. As such, patients in these cities may be going to jail instead of getting referred to the psychiatric center. Hence, the distribution that we see in the counties. So, just as a summary, we see that patients on this map are recidivizing or being readmitted to the hospital and from counties that do not have a jail present. However, when in St. Louis and Kansas City, which has counties, when they're documented for use of restraints, which is usually considered violent, they're sent to jail instead of being readmitted to the psychiatric center from whence they first came from. So it's fascinating what when mapping these conditions out, and it's very important for allocating resources and informing policy or stakeholders on what is happening in the community and how they can kind of make a difference in allocating the right resources to the correct areas.
Great, I'm sure Dr. Alifari has some additional wisdom to add.
Well, that was particular to restraints, but the way that we can now analyze, first of all, collect data and analyze it, will allow those folks who are working with mental health data, with a lot of the social determinants that go along with mental health data. If legislators want to know where they can get the biggest bang for the buck, where they can spend the money in a way that achieves parity, that helps with equity issues, and that gets everybody, the maximum number of people, the appropriate care, data science is the way to go, because we can provide the evidence that they can use to make the decisions that will enable them to spend the money that they have to spend in the right places, to make the policies that will enable the maximization of care. 10 years ago, that would have required a specific study, and it would have been a long-term process to come up with an answer. Now, I'm not sort of say it's perfect or easy, but we can get a much shorter turnaround answer, and we can do it much more frequently. So we could definitely provide some evidence if there's a need to make priority type decisions. That's my thought on it. I think it's getting better.
Thank you.
I wanted to pop in here because I want to respect some of the questions that we're getting from YouTube today. So here is one from Brittany Whitley for Elizabeth and Senator Razor. What are some of the best ways for researchers to engage with legislators outside of events like this so that local expertise is included in mental health policy conversations?
That is a fantastic question. And so I'm going to gear this very specifically towards Missouri. Our legislative session, in case there are folks that don't know, run from January through essentially May. During those 5 months out of the year, we are just very intensely looking at, am I voting yes or no on a topic? If there is legislation that's coming up and you think, Senator Razor, you've got to be a no on this, you have got to be a yes, tell me why, and then move on, because next I got to think about transportation issues, and then I got to think about higher ed funding, and then we got to think about, adoption care issues, and there's 1,000 things. If you want to sit down and have a long, in-depth discussion, now is the time to do that, the summer and the fall. So if you want to sit down with your legislators, maybe not right now, give us a few weeks after session to sleep a little bit. But now is the time to sit down and really lay things out and walk us through what you're thinking and where you see the state needing to go. Once January hits, explain why we should be a yes or no. And then that's about all we can take at that time.
Yeah, to piggyback on that, every office runs a little differently, especially on the House side. For me, I do quite a bit of policy work for both Representative Applebaum, and I also work for Representative Trish Gunby. And so there are sometimes too where it may be beneficial to take the opportunity to meet and chat with staff. And that's something that could actually happen during legislative session. Not quite as in-depth as what could happen during interim, but I've definitely got more time to spare than my bosses do, right? The other thing too, to just kind of give a concrete example, is that there's recently been established a subcommittee on mental health policy research under the umbrella of the Health and Mental Health Policy Committee in the House. And we're going to be getting that's the goal of this interim, is to, sit down, have in-depth conversations from experts and to hear perspectives on, barriers to mental health access, and really kind of get deeper answers to some of the questions that have been asked today. So if you're interested in being one of those people, or someone who should be one of those people, shoot me an email and I'll be happy to get you connected with the folks on the committee who are going to make that happen. So it's pretty exciting.
Great. And just off the back of that, I know we lost you earlier, Elizabeth, so I don't know if you want to sort of continue your answer to the initial question, which was just talking a little bit about the challenges in low-income communities and those individuals that actually suffer from substance use disorders.
Yeah, so I'm not sure exactly where I cut out, but Representative Collins just wanted to add that North St. Louis City does not have a hospital. They have one small urgent care center, but they also have one of the highest concentrations of crime, of heart disease, of mental illness in the state, and certainly in the city of St. Louis. And so it's really important to keep in mind that barriers to mental health don't just exist when folks can't reach a specialist within 100 miles. Sometimes there can be a specialist within 10 miles, but they can't get to them because there's transportation issues. Telemedicine is an issue even in urban areas. There are places in the city of St. Louis and in the county that don't have good access to internet. I'm in St. Charles County and my Wi-Fi just cut out. So, I mean, that's a challenge for a lot of people. And so it's important to keep in mind that, this issues of barriers to access kind of hits everyone from every demographic.
We wanna respect everybody's time, so we are just gonna have one more question, but we're gonna ask all of our speakers to kind of give their own take on it. If you had all the resources that you could possibly ask for, what is one thing as a professional in your own field that you would need to get more healthcare access, or to make the conversations about mental health more normal, in quotes, to normalize all this, whatever you're working on, the mental health, what is one thing that if you could have all the resources in the world, you would need? And I'm gonna start with Senator Greg Razor, please.
I was really hoping you wouldn't start with me on that one, because I'm trying to think if I could wave a magic wand, if I can put it that way, it would be to erase the stigma that surrounds mental health. That to me, and again, there are people here much more educated on this issue than I am, but to me, in my layman's view, that seems to be the number one issue. But again, we are making progress on it. Not as quickly as we would like to see, but we are making progress.
I'll jump in. I would tend to agree with Senator Razor here. I think the stigma is something that's especially challenging for me personally. When I was a freshman in high school, I was hospitalized for suicidal ideations after losing a friend to suicide. And it was horrible. And the stigma that I got when I came back from my classmates and even from some of my teachers was really, really miserable to go through. And honestly, something that I've had to learn how to deal with over the last 11 years since that's happened. So, I mean, it's certainly a challenge. And I think that, that is something that is going to be a lot harder to address through policy means than issues like, funding services and, issuing tax credits for people that pursue jobs in this field, or like whatever other creative policy solutions we have. That it's going to be really hard to address the stigma. So I would agree with Senator Razor there.
Okay. I guess I'll go next. So I would say that if I could wave a magic wand, or if I had an infinite supply of greenbacks, I would say have an easier pipeline to share research findings with policymakers, because I think that having having the power to actually change something and knowing what to do to change something are two separate things. And when you combine science and research alongside sound decision making and policy making, then I think that it would be a very fruitful endeavor. So do you have any, given your experience in this field, Dr. Alifari, do you have anything that you would do?
I think the number one way we could address all of this, having enough resources, address the stigma and so on, is if we stop considering and work towards not considering mental health sort of separate from everything else. Lots of mental health is provided in communities through churches, police departments, schools, city libraries, all kinds of places. And we don't even consider those kind of providers often when we're making decisions. Yet they're probably providing the bulk of mental health services. Doesn't matter whether you're urban or rural. More of it's happening, quite honestly, in the barbershop than is happening in a physician's office. So if we could just get away from that barrier, there would be a lot more resources available. So that's my 2 cents.
Great discussion, everybody. This was such an informative discussion and such an important topic. I just wanted to get to one more of our comments from YouTube. It comes from Thomas Huffman. Xavier is Superman. So proud of him. So I don't know how that got in there, but I think I wanted to respect our guests and get their comments in. So Xavier got his friends to inundate our chat. So thanks to them for watching. But anyway, thank you everyone for joining us. I've gone and put in the chat some information from Dr. Eleni Bickel on farm stress, and that's the link that is down in the chat. Eleni, do you have anything to say about your link?
I think can also be this is recorded. So one of the biggest things that we want to make sure that these kind of roundtables do is that you all share it with everybody who might be working directly or indirectly on this important issue. So I think Dr. Owen has already been working on our post for this event. So we're going to be sharing the link with you all. So if you can do one more thing for mental health today, before you go on your Memorial Weekend, just to share this with people that you may know. And we're going to be sending you that link here shortly enough. In the next few minutes.
Yeah. Also, we have our Zoom after party, which is not necessary for everybody here to attend. I know it's the Friday before a long weekend, so if you want to get on the road, then definitely do get on the road. But for the next 20 minutes, half hour or so, I'll be on Zoom to facilitate any conversations that anybody wants to have offline, or facilitate any more questions that anybody wants to hop on and ask. Until then, until I regret it, I'll keep posting that link in the chats after these talks. And I guess have a great weekend, everybody, and we'll see you soon. Thank you very much for attending.
Thank you.